Okay, I have with me today Professor John Ashton, CBE, who is the former Northwest Regional Director of Public Health and Regional Medical Officer from 1993 to 2006, and Director of Public Health and County Medical Officer for Cumbria from 2006 to 2013. He has also an extensive background and experience in medicine and healthcare. So we're going to discuss that today and also discuss the Lucy Letby case, of which he's been a concerned commentator. So first of all, hello to John and thank you for joining us.
Well, thank you for inviting me. And I hope that what I have to say will be of interest and value in this situation that we're faced with. I'm John Ashton. I trained in medicine at the University of Newcastle upon Tyne, and then had a broad clinical background in old age medicine and psychiatry, general practice, sexual health, family planning work, and so on, before moving into public health and training at the London School of Hygiene and Tropical Medicine. I've been in public health now for over 40 years, both as an academic and as a director of public health in various capacities, but particularly as regional director of public health in the Northwest. And I've worked extensively with the World Health Organization throughout the world, actually, in many regions, and particularly working with cities. I think that my interest in systems failure, whether it's clinical or whether it's other organizations, really stems from being thrown in at the deep end in the Hillsborough stadium disaster in 1989, when, as a spectator, supporter of Liverpool, and being present at the game behind the Leppings Lane end of the ground, I found myself caught up in the emergency response because of the failure of the ambulance service and the NHS response at the site. And I finished up having to triage the casualties, working with some other healthcare professionals, and at the end of the afternoon certifying 6 or 7 people dead. And thereafter I became caught up in supporting the families, the survivors, the bereaved, in the case against the police, against the cover-up that what had taken place. So in a way, that was a baptism of fire about how organizations can go very badly wrong. And I learned lessons from that, which subsequently became important and were reinforced by my quite extensive experience of dealing with clinical service failures in the NHS. And really brought home to me this understanding that when things go wrong, if you have 1 or 2 things going wrong, you may get away with it. But when you have a whole series of things lined up going wrong, then in a sense, a disaster, whether it's an Alpha Piper oil rig disaster or King's Cross fire or Herald of Free Enterprise shipping disaster or a Hillsborough, or indeed a Morecambe Bay or an Alder Hey, or I believe in the case of Lucy Letby, when you look back, you can see that it was almost inevitable that something was going to happen. So that's the context in which I really approached the case of the Countess of Chester Hospital, because I see this as a hospital issue every bit as much as the focus having been put on this young nurse, if we're to really understand this and get to the bottom of it.
Yeah, absolutely. So I didn't know you'd been at Hillsborough. I must confess. I mean, there's been a lot of criticism of the police recently. Do you see kind of parallels between that and the Hillsborough disaster?
I've worked closely with police over many years, and in my capacity as regional public health director in the Northwest, I worked with the 5 constabularies: Cheshire, Merseyside, Greater Manchester, Lancashire, and Cumbria. I've enjoyed very good relationships, usually with chief constables, and I've understood the strengths and weaknesses of policing in this country. Um, I think the police issues that are shared with other large organisations, whether you're talking about the NHS, whether you're talking about education, whether you're talking about private sector. In every large organisation, you will have people who, to put not to find a point on it, shouldn't be doing the job. Some of them are remediable. Others really shouldn't be doing the job. And in my experience of dealing with doctors who are in trouble with the General Medical Council and with the police and other things that doctors get into trouble with, I would say that maybe 1 in 20 doctors fall into that category. And it's probably the same in other walks of life.
Mm.
Um, I don't subscribe to the bad apple theory. I think usually if an organization is functioning well, it will deal with the rogues and with the bad apples in its presence. What's really disturbing is if you get a group of underperforming or rogue professionals in the same place,
Mm.
and where you can get a kind of microculture of delinquency and of poor behavior, which puts the public at risk and risks the reputation of the organization itself.
Yeah, I think very fair comments. Um, so I want to ask you about Lucy's case because you've spoken prominently about this, and I know you've co-authored, been one of the co-authors of a document on this. So how did you first hear about it, and why? I mean, I think I can to some extent guess why you became concerned, but do you want to tell us the story of how you became interested in it?
Well, I'm a news junkie. I read newspapers every day. Sometimes I read several newspapers. I really get, I'm a compulsive keeping up to date and being aware of issues. And quite early on in the trial of Lucy Letby, I woke up and thought, this is just craziness. This sounds like a dysfunctional hospital. And this sounds as though, given what we're hearing in the court, that this is all circumstantial evidence which seems to have been mobilized and focused on this one young individual. So that was where my initial interest began, whenever that was, 2 or 3 years ago. And I got in touch with Felicity Lawrence at The Guardian and said to Felicity, are you following this? Are you aware of this? Are you interested in this? As a result of that conversation, Felicity started to take a forensic interest. And she and David Kahn have since written a number of really important articles about the whole thing. And they've proved that we still do have very good investigative journalists in this country, despite the often parlous state of the print media. So, that's where I got involved. And then, of course, I've been involved with others, with colleagues from my past when we had to take action. I mentioned over Morecambe Bay, but I was involved heavily with the Alderhay scandal. I'd had to suspend the breast screening service at Carlisle because some women had been told they hadn't got breast cancer when they had, because of the failure of doctors to keep up to date in the screening protocols and so on. And so I've had quite a broad experience of dealing with both systems disasters in the NHS, but also rogue doctors, where you've got, doctors who are doing things that they never were trained to do, have strayed outside of their skill set, and so on. And I'm very much aware of the tendency of doctors, again, I don't think they're different from any other professional group really, but to close ranks and to mind their own when things go wrong. I mean, when I first became regional medical officer, it was expected of me that I would be the doctor's doctor, that I would look after the doctors, those who were in trouble, who had drink problems and that kind of thing. And of course, one has a duty of care to staff, and one always has tried to exercise that. But early on, I made it clear to senior medical colleagues that I could not be the doctor's doctor. I had to be the people's doctor, primarily protecting the well-being and the safety of the public, whilst being respectful of my colleagues. I mean, I've had a fantastic, enjoyable career in medicine. I've reached significant levels within the NHS, and I hold some of my closest friends within the NHS. But this goes to the heart of the difficult task that hospital doctors and senior doctors have if they're in management positions as well, that they need to have a distance from their colleagues that's dictated by the primary responsibility to the public, whilst balancing that with a duty of care to their colleagues.
Absolutely. So you've already touched upon, to some extent, your concerns about the Lucy Letby case. Would you like to explain why, what your view is on this today and how you feel about the conviction and the situation as a whole?
Well, it's all been well rehearsed, not least in your own contributions to this. I mean, and if we start from this perspective about the lining up, like in a Gruyere cheese, the holes or whatever, we have all these different things that come together. So here we had a hospital that had ambitions above its station. The Countess of Chester was an ordinary local hospital. It wasn't a teaching hospital. It was a hospital that we have many of them around the country. Some of them do a very good job. Others do less of a good job. Part of the problem is that in many ways, the most capable doctors finish up in the teaching hospitals and in the hospitals in the cities and so on. And it's often doctors who maybe have struggled, haven't been as strong at medical school and so on, finish up in some of the other hospitals. And there's a paradox that the hospitals that really perhaps need the most attention paid to standards and to improvement may not have the right kind of leadership to achieve that. But what happened in the Countess was that it was a political agenda in the early years of the 2000s to encourage them to become foundation hospital trusts, to grow their business, using that word inappropriately for healthcare, and to extend their range into things that they perhaps hadn't been doing before, which is what we saw at the Countess. The Countess was one of the first handful of hospitals in the country to tick all the boxes to become a foundation trust hospital. And initially there was some money available to help them with that. That money later dried up. And that money, when it dried up, of course, lay behind some of the cuts in the services that then took place after the first few years. so that you had this contradiction of a hospital that was beginning to take much higher risk babies, but had got rid of some of the more specialist nurses, didn't have the clinical strength in depth, didn't have proper neonatal specialist pediatricians, and was itself in some difficulties from the point of view of the fabric and the estate itself. And, that came into prominence during the trial, but wasn't really given much attention when we heard the stories about sewage leaking through the ceiling above the baby cots. So the approach of the hospital itself, and what you could see as being potentially a collusion between hospital managers and hospital clinicians to really claim to be able to do stuff above their own capabilities. And so that was, I think, for the want of a nail, the shoe was lost. For the want of the shoe, the horse was lost. For the want of the horse, the battle was lost, or for the want of a nail. And the nail, I think, was possibly the the political push to have foundation hospitals on the basis that if you had competition between hospitals, this would reduce the costs of running hospitals. They become more efficient, they become cheaper to run, and so on, something which has proved to be fallacious, as we now see around the country, particularly maternity and infant health clinical services in trouble in many places. So that was the first thing. The second thing was really then this whole issue about expert witnesses, and the whole experience of having somebody who was supposed to be an expert witness but was well retired, wasn't even on the medical register at the time, certainly hadn't had the depth of experience in neonatal medicine that would have been required to give expert witness. And a problem that we have in this country, that there's no quality control over expert witnesses. And, the fact that at the trial itself, the fact that the expert witness in question was said to have been totally unsuited to a previous case, but that was allowed to continue, was profoundly disturbing. The police themselves in Cheshire seemed to be in a different place from when I'd had dealings with the Cheshire Constabulary until 2006, when I left my post at Region. In as much as they had problems, they'd had suspensions of police officers in Cheshire for nefarious activities of one kind and another, and the Chief Constable himself was the subject of an investigation for various reasons. And I think this was a constabulary in some disarray and needing a good story to position itself and rehabilitate itself. The pressure that was brought to bear on the hospital, on the police force in Cheshire by the doctors from the hospital was inappropriate. And as somebody who's had dealings with the different arrangements that are in place to safeguard children, I'm thinking here of, and mothers, of the what started out as something called KESDI when I became regional medical officer, which was the confidential inquiry into stillbirths and deaths in infancy, and it has since become known as EMBRACE, which is the mothers and babies reducing risk through audits and confidential inquiries. That doesn't seem to have been brought in to the story at all, or if it was, it didn't feature to the extent it should have done. All maternal deaths and deaths of children under the age of 18 have to be reported to the Child Death Overview Panel. It's not at all clear what happened with regard to these infants. I mean, we know that all but one, I think it was, of the babies for which Lucy was charged with their murder had post-mortem examinations which hadn't found anything untoward, and the coroners themselves was satisfied. But the other mechanisms as well don't seem to have been engaged with by the clinicians. And the General Medical Council, which is responsible for policing good medical practice, there's a booklet which you can find online and which determines the parameters of what good medical practice is all about. It's called Good Medical Practice. Really requires clinicians, in order to maintain their license to practice, to keep up to date with protocols, with the things that they should be doing, relationships, as I would suggest here, with paediatricians and with the Child Death Overview Panel and the other bodies that are there. But the clinicians seem to have gone to the police rather than engaging with the peer group review processes that would have drilled down and carried out forensic clinical examination on the circumstances of anything that there should have been cause for concern. So here we have a lining up of an inadequate hospital, a police force in trouble, a questionable approach to expert witnesses, behaviour by clinicians who don't seem to have been fulfilling their duties of a doctor. And then, of course, the statistics that were produced for the trial were a total travesty of the use of statistics. I mean, it's a cliche which we've all grown up with, that there are lies, damned lies, and statistics. But there are also extremely good, solid statistics. And in Professor Jane Hutton from Warwick, who I worked with when she was a lecturer at Liverpool Medical School, and is one of the top medical statisticians in the country, she was initially approached by the Cheshire Constabulary to provide evidence, and then she was told she wasn't needed. But Jane Hutton's analyses, and then all that of many other statisticians since, senior statisticians from around the world, pointing out that this was a gross abuse of statistics to produce a chart that aimed to prove that Lucy Letby was there whenever babies died, but didn't look at the circumstances when other babies died, but when Lucy Letby wasn't working. And so all these inconsistencies in the evidence began to come together. The specifics that were thrown at the jury to do with these theories, and that's what they were, of method of killing using air or insulin, other traumatic things. These have since been systematically dismantled as lacking any evidential base at all. But at the time this was emerging, it all seemed remarkably unlikely. And taking again another perspective, what in the trade we would call the pre-morbid personality of Lucy Letby, and I speak here as someone who trained in psychiatry many years ago, before I went into public health. This young woman showed no signs in her personal life of any untoward behavior, no delinquency, no neurotic symptoms. There was no psychiatric assessment done that showed any tendencies in any direction. And this all seemed really bizarre, that the focus was going to be on her. There are probably other things there that I've omitted, but the lineup of weaknesses and grossly misleading approaches, I think is pretty clear. What was also problematic, I think, is that, you know, there was this doctor at there's this doctor at the Countess of Chester who appeared to have a very close relationship with Lucy Letby, with over 1,000 social media texts to her, many of them late at night, the trip to London, and you know, apparently a married man, with a reputation and a marriage to put at risk, you know, who was granted anonymity at the trial, having initially been one of her supporters. And this hasn't really been subject to much examination, but you have to wonder why somebody who had really regarded her as an outstanding nurse, as many other people had done and all her colleagues did, and came to her defense in the early days, then turned on her and gave evidence against her. And you have to wonder whether the fact that apparently, and we don't know the detail because it's not in the public domain, you know, that he's now apparently in a very senior position in medicine. He had a career to protect, he had a marriage to protect. And is this right? Is this lack of transparency right when a young woman's life is at risk? There are others who have granted anonymity for reasons which are very obtuse. You know, this is supposed to be justice being done and seen to be done, transparent, fair to all. And yet we had these very strange circumstances around the trial. So every bone in my body tells me that we're looking at something here that smells. And that's, you know, it's not just my instinct, it's my experience, and it's the evidence that has been assembled by a large group now, a large group of multidisciplinary experts from around the world.
Absolutely. So I just want to pick up briefly on one of the things you mentioned in that answer, which is that you described the medical evidence used in court as theories. So I've said quite a few times, I think, on this channel that there are no diagnoses in this court case, and what Dr. Evans describes as his diagnoses are theories or hypotheses. So do you think that's a fair comment?
Yes, they are. And, you know, medicine is a science and it's an art. And the science that lies behind our understanding of respiratory physiology and of you know, sugar levels and insulin and all of these different parameters that were introduced, they were sort of throwing things in, everything but the kitchen sink, without any coherence, no, not even a modus operandi that might have been rehearsed and followed through. You know, why would somebody use different methods of killing on different occasions? I mean, you know, occasionally in this discussion, Harold Shipman's been brought into the discussion. You know, he was a man who clearly had a very weird personality and attitude towards the elderly, but he had a modus operandi. It was the same for all of them. You know, he went visited them at home in the afternoon and saw them off, and that was what he did. But the idea of invoking these very odd explanations that, you know, on the one hand, would have required large quantities of insulin to be consumed from the medicine cupboard without being noticed that they've been used up, and all this kind of thing, is very, very strange. And I think those of us who've had to deal with legal things over the years as well, and I speak here as somebody who believes in the jury system as well. But when you get something like this happening, you realise that how difficult it is for a lay jury to deal with heavily dense scientific evidence without proper instruction and support, and being led by people who don't have skin in the game. And one of the troubling things about this is it seems as though the prosecution expert witness had skin in the game in the form of the large amount of money he got paid to see his children through private school and all the rest of it.
Yeah, absolutely. I want to ask you about Dr. Evans, in fact. What have you made of his conduct, I think, both during and after the trial?
I find the lack of professionalism in the engagement with the media very disturbing. And what we saw, of course, here, because of the way in which the media was barred from talking about certain aspects of the trial, but on the other hand, you had champions for the prosecution in the form of the Daily Mail and other so-called journalists who really took sides in this early on and were protagonists. That was this unholy alliance between the prosecution and the Fourth Estate. I think Dewey Evans' behaviour has to be understood as well in respect to a lifelong or a professional lifelong focus he's had on what's called Munchausen's by proxy, where Munchausen's by proxy, Baron Munchausen was Richard Asher coined the Munchausen syndrome based on Baron von Munchausen, who lived in a fantasy world. And the idea of Munchausen syndrome is that this is people who might get vicarious attention to themselves by harming somebody else and getting involved in the medical care system, usually perhaps a parent and a child, and harming the child to get attention. This concept has come under great criticism in recent years, but it was a fashionable diagnosis for a time when I was starting out actually in medicine in the 70s and 80s. And this is something which Dewey Evans has had a long-standing interest in, and which he, in a well-publicised case where a young girl of 11 or 12 who had abdominal pain and had been seen at Great Ormond Street and Alderhay and had her appendix out and still had abdominal pain, and where Dewey Evans got involved with her from his hospital in South Wales and claimed that she had Munchausen's by proxy when her mother took her off to America to try and get another opinion. And this girl was dragged back from America as a result of the intervention of Dr. Evans and the local director of social services, and wasn't allowed to see her mother again. And I don't know now what's happened to her. She must now be in her 50s or so. Hopefully she's still around. But, this was a very early focus of this doctor. And when you think about it, the accusations against Lucy Letby were rather similar. They were that she was harming children to get the attention, particularly of this doctor who's been granted anonymity, so that he would come down to the ward and she could spend time near him on the ward around the cots with the babies. So in a way, it looks as though this focus on Munchausen's by proxy has been a thread in Dr. Evans' work throughout all these years.
Yeah, I mean, they were certainly trying to hint at that during the court case. Frankly, I think it's utter rubbish because she already had his attention. So I don't know why she would need to get more attention. I just think I don't think even the prosecution really believed in it, but I think it was undoubtedly a strand that they tried to bring in there. So we're going to talk about some of the kind of specifics related to the hospital, related to your area of expertise, and so forth. A couple of which you've touched upon already. First one is the junior doctors who are on the unit. So it's been pretty well documented that there were insufficient skill sets and experience on this unit. So I just wondered if you could explain how the prevalence of junior doctors on the unit is kind of indicative of a gap potentially in the skill sets at this hospital.
Well, the medical curriculum has become more and more crowded because of advances in medicine over the last 30 or 40 years. And the dilemma that medical schools have is just how deep can they go in the 4 or 5 years that medical students spend in the classroom and on the learning environment on the wards and in general practice. And so I think it's generally recognized that when you graduate now, um, you've really got the basis for being a doctor, but you're not safe to be an independent practicing doctor for at least another 5 years, doing a specialist training of one kind or another. And to really be on top of the job, you will still need to have, even if you're in old terminology of being a registrar or a senior registrar, you would still need to have access to consultants to come in at night time or at weekends. If you're a 10-year experienced doctor and you're at the front end and your consultant is at home, there'll be times when the consultant will still be needed to come in and to supervise or to advise over the phone and so on. But when it's about neonates and it's about maternity, then it's really important that we have what's called now consultant-led service, so that you've got consultants who are actually doing the job as well and not just delegating it all to a senior registrar or a registrar or even a houseman. And in this case, it seems that at times there would be a doctor there at night who was on the general practice rotation scheme and who may not have done any other pediatrics. I did a 6-month pediatric attachment in Newcastle all those years ago, but I was never there on my own. There'd always be a registrar and a senior registrar around, and the consultants were very conscientious, and they'd come in at night and do ward rounds. The thing here as well, which is really remarkably disturbing, was the word from the Royal College of Paediatrics and Child Health report that they were only doing ward rounds twice a week. So you didn't have consultant expertise in depth. They weren't practicing systematically to a high standard, and they were leaving juniors to deal with really difficult work with very low birth weight babies who had very serious health problems. So this, as Dr. Lee from Canada said, who chaired the panel of international experts, if this hospital unit was in Canada, it would have been closed down.
And that's about as damning as you can get, isn't it, really? So yeah, let's talk about the child death overview panel. So this is something that I'm aware of, but I don't know too much about. But you believe that it has significance and importance in the Lucy Letby case. So could you explain that, please?
Well, it's a mechanism which has evolved over time. When I was first regional medical officer, I had a a very experienced, actually, she was one of the first consultant midwives in the country, Grace Edwards, who used to be responsible for the KESD, Confidential Inquiry, Stillbirths, Deaths in Infancy, for me, for Mersey region. That was replaced in the last 20 years with a sequence of different arrangements that brought together the perinatal epidemiology unit at Oxford with others. And because, let me say, fortunately, infant and child death is not common. You would think, because we've got problems with it, that it was. I mean, but the numbers of deaths under the age of 18 in any year in a district like Chester, you would count in the dozens. That's all deaths under the age of 18, and a big proportion of those will be things like road traffic accidents and other accidents. A big proportion of them are the consequence of serious congenital abnormalities that aren't compatible with life. There's been an argument, which is now being resolved in favour of stillbirths being reported into that system. They didn't used to be until last year. And when I was working in Cumbria, I had an audit. I commissioned an audit into the stillbirths in the county. I commissioned it from Oxford, and the thing about it is that death in the uterus, stillbirth, or babies that die in the early neonatal period, there are very important lessons to be learned from examining those closely. And unless they are notified in properly, and I discovered that wasn't systematically happening when I was working in Cumbria, and we took steps. My colleagues who shared the medical director function with myself took steps to try and get on top of that. But there's a sense in which some hospitals tend to regard stillbirths as acts of God, whereas actually they're not necessarily acts of God at all. And we know that not all antenatal monitoring is done at the standard it needs to be done. And stillbirths need to be subject to respectful examination. It's obviously very delicate for the parents as we talk about these issues and we talk about these babies. These parents have to be at the front of our mind. I mean, we've experienced early childhood death in my own family, and we are sensitive to these issues in our family. But the fact of the matter is, just for example, something like 40% of stillbirths, the mother has been a smoker. Now, how do you handle a piece of information like that? You have to be very careful. You don't want to be guilt tripping people, but we need to be supporting mothers and pregnant women in doing the best for their unborn child. And we need to monitor those kind of things. And we need to see what the outcome is of babies who haven't had an eventful experience in the womb. So the importance of the Child Death Overview Panel is to identify patterns and trends in the numbers, but also in the nature of where things go wrong. And so, because there aren't that many every year in any particular district, the arrangements were changed a few years ago to have child death overview panels for bigger geographic areas, so that you had more numbers of these sad events, so that you could explore them and see whether there's any emerging patterns. So the child death overview panel for Merseyside and Cheshire, I think it probably is now, would have the sort of numbers that one might be able to begin to make sense of. And if they were aware of babies being coming to grief, coming to harm, then steps could be taken to make sure that there's an understanding of what was going on and do what was necessary to intervene. And of course, that depends on the timeliness with which the Child Death Overview Panel is notified. And that can be a problem. It can be a problem. It can be a problem getting hospital staff to realise the importance of notification systems. I've come across that again in A&E departments, because the data that is held in A&E departments can be really invaluable if it's analysed properly. For example, in finding accident black spots on roads or in other places. But often the clinicians in a casualty department, in an A&E department, can't see the purpose in feeding data to a body that's not part of the NHS.
Yeah, absolutely. So again, another thing you touched upon that I wanted to discuss. Again, this is not something that has been, I think, broadly discussed in relation to Lucy's case very often, is this foundation trust status, and the way the NHS evolved in relation to that. So could you kind of explain the significance of that, please?
Well, I think I've really covered that, but we had this whole movement dating from the 1980s and 90s of trying to either privatize public sector organizations or make them much more like private sector organizations and encourage them to compete with each other rather than to cooperate. We saw it in the universities, getting the universities to collaborate with research proposals and research activity was very difficult 20 or 30 years ago. The emphasis has changed now, and the emphasis is more on getting the universities to work together in networks of a particular projects. And we've seen that particularly perhaps after the pandemic. But it's been the same. It was the same with schools, with local management of schools, when the local authority education departments were taken off the pitch, and were the regional health authorities, the regional hospital boards, as they originally were, and which had oversight, were taken off the pitch, and the hospitals were given autonomy to aspire as high as they felt like. And that's the weakness here, I believe, is that the Countess of Chester, not to put too fine a point of it, had aspirations beyond its capability and its capacity.
Yeah, absolutely. I think, I mean, I never like to comment on this too much because I don't know 1% about it compared to you, but it's something that a lot of people have said who are, healthcare professionals. I mean, I often get comments related to this. So you weren't the first person to raise this, but I just didn't really feel qualified to comment. Obviously, I know that finance can always be a motivating factor for any system, particularly in the NHS, where it can be a premium. But I didn't really know too much about it. But it's certainly interesting to hear about it.
On which I think you may wish to just capture is this whole issue about who runs a hospital. In 1983, Sir Roy Griffiths, who was a director at Sainsbury's, the grocers, was brought in to do a review of the National Health Service because there was concern that the consultants, who since 1948, when the health service was set up, had, in theory, been there to provide clinical leadership, hadn't really been exercising that leadership, hadn't been managing change, hadn't been looking forward to see what was coming down the track and what needed to be done to be fit for the future, and so on. Because what we had from 48 onwards till 83 was we had consultants who were very powerful, but who really often weren't interested in management. And we had administrators of hospitals who'd been brought in from other bureaucratic organizations, maybe ex-military, maybe ex-colonial service, to run organizations, but didn't have the background or the clinical expertise and didn't have the powers to really intervene where there was clinical service issues. So Sir Roy Griffiths famously said, if Florence Nightingale was walking around one of these hospitals today, she would be trying to find out who was in charge without much success, you know. I mean, Florence Nightingale was probably the first hospital manager of a kind who used statistics out in Crimea. She used to collect the statistics of deaths in the hospitals, and she used those statistics to guide changes to improve the safety and the hygiene standards and so on. If you go to Liverpool, to one of the original Nightingale wards that she brought the design back from Crimea, they were round wards with a central fireplace, and the beds were radiating from the central fireplace with the head of each bed by an open window, so that the patients got the fresh air treatment, and that you reduced the spread of contagious disease among patients. That she based all that in bringing that design back from Crimea, something that the Belgians had pioneered actually, and that use of statistics to be used to manage change in clinical practice, none of that was happening. And so as a result of Sir Roy Griffiths' report, the Griffiths report, they brought in what was called general management, and all the hospital consultant, most of the general managers, the chief executives, whose status was greatly enhanced after 1983, you know, paid a lot more money, they went through the national training program and so on. But they were supposed to be empowered to make decisions and really put them in a stronger position vis-a-vis the medical consultants. But that tension had continued to exist between who really ran it. Was it the doctors or was it the general managers? And so about 25 years ago, I think it was now, they introduced medical directors and clinical directors who were given, and this was really about trying to find doctors in hospitals and in other parts of the NHS who were interested in, and nurses who were interested in clinical management and clinical leadership. Now, I can remember when I was charged with finding 40 or so medical directors for all the hospitals in the Northwest, along with the chairman of the Regional Health Authority at the time, Alistair Breckenridge. And we struggled to find the numbers of people who we really thought had the aptitude and the ability to take on responsibilities for being medical directors and then clinical directors within each of the clinical specialty areas. And we embarked on a development program for those that were going to take on these responsibilities. But it's clear, and we see it from the Countess of Chester, that not all these people were up to the job. And the issue about the relationship between them and the consultants, and the extent to which the consultants from time to time are seen to be not corporate, slagging off the general management and the general management not being able to take the clinicians with them on a journey of change, that we still haven't got it right. Because ideally, what you need is people who understand the business, who've got some kind of clinical background, but who really, for whom management is second nature, and who can personally distinguish between respectful, collaborative behavior with their clinical colleagues and standing back and recognizing their primary duty is to the public. It's the distinction I drew at the very beginning of this about how I understood my role when I took on the regional job.
Yeah. You mentioned earlier this self-policing of consultants, and I know you have a very interesting answer to this question, so please don't feel that you have to restrain it in any way. Why does this apparent culture exist in the NHS where consultants are so seemingly unchallenged?
It's something which has surfaced in a dramatic way from time to time. It's something which Sir Liam Donaldson, when he was Chief Medical Officer for England, took a particular interest in. And it was something which surfaced when we had the Alder Hey organ retention scandal. And what we found at the Alder Hey at that time was a caricature of this kind of culture. Liam, in his very important report that was published in 2002 called Organisation with a Memory, drew on the lessons of the airline industry. And there you had the example of the Korean airline, which had the worst safety record in the world, I think. Whether it was worse than Aeroflot, I don't know. But a very hierarchical culture where, to caricature it, if the plane was about to fly into the side of a mountain, the second officer wouldn't dare say anything on the flight deck because it's so hierarchical. And the situation at Alder Hey at the time seemed to be the same. We had a situation where often a theatre technician, fairly lowly in the hierarchy, but very much an expert in their own part of running an operating theatre, might see something going wrong, but didn't feel able to draw their attention of the consultants to what was happening. You know, I mean, you can imagine the sort of things that do happen in operating theatres, so-called never events that do sometimes happen, like leaving an instrument in an abdomen or something like that when the abdomen's being sutured up. And where what Liam Donaldson really was so concerned about was to create a different culture where everybody's voice could be heard, and from the lowest to the highest could be heard. And that organisation with a memory has still not been fully implemented in the NHS. You know, the idea that you should be identifying near misses and learning from them. You should be working towards a no blame culture so that people don't cover things up, but they put their hands up if they've done something that, you know, made a mistake, and everybody can learn how to do something about preventing that happening again. It was one of the things I learnt working with Sir Donald Wilson at Mersey Regional Health Authority early on. Whenever we had a problem in the health service, he was very good at this. I mean, he basically, his whole approach was to find out what had happened, and you know, hands up. There's been a mistake made. We're onto it, and we're going to make sure it doesn't happen again. That was his approach. It wasn't to cover it up. There are reasons why hospitals cover things up, to do with the advice they often get from lawyers about litigation. But if you look at the Countess of Chester, it's not just the neonatal unit at Countess that was in trouble. The maternity unit had a lot of problems in the same period and had paid out millions in compensation to families where things had gone wrong in a maternity unit. And, so it's clearly a sign that they weren't operating an organisation with a memory, a learning from near misses, and an open culture.
Yeah, absolutely. And speaking of an open culture, the elephant in the room for this hospital is the sewage on the unit, and that's coming out the sinks and so on and so forth. How can that be allowed to happen? Whose responsibility is to escalate this? Why didn't that happen? How did they think that they could just sort of mend and make do while this was occurring? They're sticking nappy pads to the ceiling and such like. I mean, what the hell is going on with the sewage?
Well, I think you put your finger on another thing which is really rather important. I as regional medical officer, had to deal with outbreaks of Legionella at some of the hospitals in the northwest. I remember particularly one at Broad Green Hospital, where there was a problem, but we had been told about it. We're able to intervene. But the real question is, who on the hospital board of management is responsible for keeping an eye on those things and for asking the questions about it? Who's responsible for making sure that in the annual report of the hospital, these things are written about, and that from year to year, the actions have been taken to remediate them? And I would suggest to you this seems to be a real weakness of the Countess. If I tell you that I, as somebody who's very experienced and has had a strong professional career, have applied for probably 10 hospital boards to be a non-executive director and have never been shortlisted. Now, I have a reputation for asking difficult questions. And I think the problem is you need people on boards of management who will ask difficult questions. In my experience, in my view, hospital boards clone each other. They're all very similar people, and they're over heavy with people with a finance background, because that's been the obsession of government and of the NHS for the last 40 years. So the boards are rich with finance people, but how many of them have somebody with a public health background or an environmental health background, or who really understand those questions that aren't the bread and butter of daily clinical practice, but impact on the clinical quality of the service?
Yeah, so what one can see why they would have finance people is because there's this push to be more efficient. But do you think there should be some sort of requirement to have medical, at least one medically or two medically qualified people on boards, possibly?
Well, it's not about medicine here. It's about public health or environmental health on the one hand. You'll also find that very few hospital boards have somebody from a housing background. But every day you'll read about all the people waiting in hospital because they can't go home to their home anymore and they need to be rehoused. But there's no housing voice on the board because the NHS is very poor at making the connections to other agencies.
Yeah, well, that's interesting. So one question we often discuss in the comment section on this channel, and there's a spectrum of opinions on this topic, and it's something I've never come to a satisfactory conclusion about myself. Why did they go for Lucy so quickly? Why? You can see documents from June 2015, and certainly by July, they're already talking about commonality. Was anyone on duty all the time? Rather than looking at all the things we've discussed already, all the problems on this unit, all of the issues that could have collectively created this clinical picture. Why? What? They're sticking their neck out so much. They've gone for the police. So they want so much for the executives to phone the police. Why did they go for Lucy so quickly and so hard, seemingly? Do you have any thoughts on that?
I don't want to get into the realm of conjecture here. I think we may be getting into issues of the individual psychopathology
Mm.
of the people involved. Because in Freudian terms, what we might be talking about here is projection, is people who might have begun to realize that their own clinical practice is less than good enough and may actually be bad, but rather than look in the mirror, prefer to point the finger at somebody else. And the question is, for each of these consultants and the ones that really decided to go for Lucy, what was the motivation of each of them in this, whether it's the medical director or whether it's the consultants themselves, whether it, J.R. Who seemed to be particularly exercised about this, what was going on in his mind, and given now the contradictions in his own testimony, what was all that about?
Yeah, it's hard to say for sure. But I think that I've tried to reflect on this, and if you look at the consultant body as a whole, it's clear that Dr. Brewery had a big influence over them, and he was the kind of foremost communicator, certainly the pioneering communicator, the idea that it could be a nurse, and then he became more and more concerned with it. It seems that I know from the thermal inquiry documents, he did have a big influence over them. So why he initially felt this way, I don't know, but I've always felt they're taking such an enormous risk. It just seems so strange to me, but there you go. I mean, it's happened, so we just have to deal with it, I suppose.
Well, I
Um,
think there came a point here where there was no going back.
yeah, yeah, that's a fair comment. I think a lot of people say to me, once the grievance had taken place, they just viewed it as an all or nothing situation, basically, and they were going to pursue. Well, they said it themselves. They actually said, "Yeah, okay, we've had the grievance, we've had to say sorry, but that's not changed our attitude, and we're going to carry on the way we were before." So I think that probably hardened the resolve. I think it's fair to say. Um,
And she was a young woman who had guts as well, because she
mm,
blew the whistle, really.
yeah, and maybe you could just give me a few thoughts on, the kind of level of courage it takes to take a grievance out against basically an entire consultant body.
It's a big deal for a young nurse. It's a big deal for a lot of people. Consultants have such status, but I mean, in the run of everyday life, people tend to keep their heads down. This is one of the sorry things about life. I mean, I'm a proud Liverpudlian. I've always been proud of that bit of the Liverpool heritage that means that people have a reputation for standing up for what's right.
Mm.
But when you travel around the country, you find that the cultures aren't all like this crazy place that I come from, and that people want to keep their heads down.
Yeah, yeah, that's a fair comment. I never really. I mean, I guess I come from a similar type of place, and I've spent time in Liverpool, so I know what it's like. And yeah, I think there's a lot of truth in that. I want to ask you finally. I've got a few questions I want to ask you more broadly about the NHS, particularly about the time when you were the regional director of public health and so forth. So the first one is I just want to ask you to provide and reflect on some examples of clinical service failures from when you worked in that position.
So you're asking me about my experiences of major issues.
Yeah, particularly obviously when you were the regional director of public health. Any kind of,
Yeah.
I know there were several, so yeah, if you'd like to tell us a little bit about that, that'd be great.
Well, yeah. Well, the big issues that took place during my professional lifetime were um, Alder Hay, the organ retention with Van Velsen, who was a pathologist who had this massive collection of organs and parts of babies and children that no permission had been granted from the parents. I mean, I went along to explore what was going on there, and there was a room in the basement at the university where he had all these paint pots um, housing, dozens, hundreds probably of organs, and it was the lack of insight and the lack of interest by the Alder Hay Hospital itself that had allowed this to happen. But on the back of that, then it became clear that there was a big difference in outcome for babies having cardiac surgery, and I had to oversee a review of the practice of the pediatric cardiac surgeons, and that was very difficult because I had to deal with the families who were very upset, obviously, and I had to engage with them and reassure them that we were going to make sure that this was properly got a grip on and it wasn't ever going to happen again. And it raised all kinds of issues. The problem is that at that time in England, there were only about 20 or 30 pediatric cardiac surgeons, and some of them had much better results than others. Mm. And not every family can have the same pediatric cardiac surgeon. What you have to try to do in a situation like that is to bring everybody up to the same standard. And that, is a major exercise and takes time. The shipment thing happened on my watch, but we only got to find out about it, after the police got involved. And when we did that, and there was a review again that Liam Donaldson was responsible for, which showed that this massive statistical excess of deaths in that general practice if we were monitoring for general practice, if we were monitoring properly hospital activity, if there was somebody in each hospital who had epidemiological expertise, if there was somebody in each primary care group with epidemiological expertise, then you'd be in a position to see when patterns like that were emerging. And the role of somebody like myself has really been to identify these questions and these issues that need to be picked up on. I mentioned the Carlisle breast screening service, and I mentioned the Morecambe Bay. The Morecambe Bay, what happened there was that I discovered, that the death of women in child who are pregnant has been a very interesting social story. In the 1930s, there were approximately or approaching 800 or 1,000 women dying in childbirth every year. And as a result of that, the confidential inquiry into stillbirth and death in infancy, into maternal death, was set up. And that mechanism of really looking in depth at every maternal death had dramatic impact on improving and reducing the death toll. So that when I was a junior doctor 40 years ago, those numbers were down to the dozens. They're back over 100 now, and we don't know quite what's going on. And there seems to be an overrepresentation of women from overseas, which raises a lot of questions about whether the service is being provided in a culturally appropriate way to enable women from different backgrounds to get proper access, But at Barrow, I became aware that there'd been 3 maternal deaths in 2 years. So in a small place like Barrow, with a population of 65, 70,000 people, to have 3 deaths in 2 years, when nationally, at that time, there'd be less than 100 for a population of 60 plus million, that got the antennae up. And then, became aware that babies had died, early neonatal deaths and so on. I was visiting the medical director of Morecambe Bay, and while I was with him, he got notice of a baby that had died 3 or 4 months before. I said, well, why are they only telling you now? Why are they only telling you now? So there wasn't a system of prompt and timely notification. The interesting thing about that as well, which speaks to something I said earlier, was that he, as the medical director, wasn't even on the same floor in the hospital as the chief executive, when you might think they should be in adjacent rooms, so that they're on a daily basis of daily conversation. So these were the sort of things that got me concerned. And the fact was that when I finished working at Region and I took up the challenge of another few years in Cumbria, we discovered that we weren't being told about when things went wrong, when there was a death or of an infant, or when there'd been a near miss. I mean, I remember one instance where what we used to call a senior registrar had wanted advice and support from the consultant, but the consultant didn't come in, and the result was a child that had damage to it, because the conversation was just over the phone. And those sort of things, other people will have similar experiences. There's lots of individual things where, this sense of entitlement, when a senior doctor came to see me one day and said, I want a merit award and I want you to put me up for a civic honour. I said, I'm not doing that. That's not the way it's done. I mean, it's a flavour of some of the things that you have to deal with. But in my day, there were 9 of us regional directors, and we had to operate what was called the alert letter system, so that if a doctor was in trouble with the General Medical Council and was being suspended or whatever from practice, then the regional director of public health was notified and had to write a letter to each employing organisation in their region. So each hospital and each general practice or whatever. So write a letter warning them in case this person turned up on a Friday night to apply to be a locum for the weekend or something like that. Well, in the Northwest, I had over 300 of those. And that's where my sense about the extent of which poor practice is to be found, and why it's so important that we have ethical leadership of the profession, and that the idea that you call things out when they're going wrong is just not unacceptable.
Yeah, absolutely. So last couple of questions I want to ask you. Firstly, I just wondered if you had any reflection on this maternity crisis that is very evident at the moment, with massive negligence claims being put in, and certainly in the media, maternity was cited as being a major factor in this. So do you have any kind of thoughts about that?
The starting point here has to be the health of young women and adult women who might be going to have babies. That's the starting point. Sir Dougal Bird, who was a very highly esteemed professor of obstetrics from Aberdeen and who trained many of the professors of obstetrics in England, used to say that it takes 3 generations of good nutrition to improve obstetric performance. That's using a rather medical mechanistic word for how well women get on delivering babies.
Yeah.
But we've got very poor nutrition in this country. There are growing social class differences in obesity. Again, it looks as though growth in terms of height is varying again in ways that it used to do enormously. I can remember going to Newcastle as a medical student and all these little men under 5 foot who must have been children in the Depression in the 20s and 30s, But we're seeing poor nutrition. People aren't being grown to their full height, and women to the full pelvic size. And then what's happening is we've been very successful at reducing the number of pregnancies that occur to teenagers. So that's been a success story. It's still not as good as Holland or Sweden, but we've done very well. But now there are more babies being born to women over 40 than under 20, and they're much higher risk. And when you couple that with the obesity epidemic that we have, if you talk to a director of obstetrics, they'll tell you they've had to get bigger beds for deliveries because of the numbers of obese women having babies. So these are all problems about, public health problems that we need to address to make sure that we've got fit women having babies and so on. When it comes to the actual experience, then you have some dilemmas. I mean, the Royal College of Obstetricians will tell you that in order to fully staff an obstetric unit and have the right workforce covering sickness and holidays and so on, you need a unit which will be doing about 4,000 deliveries a year. But when I worked in Cumbria, we only had 5,000 deliveries a year in Cumbria, spread between 3 obstetric units. And people are very reluctant to lose their obstetric unit and travel even maybe 3/4 of an hour to a place further away from home. And that's about a public discussion and an understanding of what is best. I mean, if you go to Liverpool, you'll find that women come into the women's hospital from all around Merseyside because it's got such a high reputation. And so they are, they're looking after a large number of women having babies every year. So there are those issues. But then what's usually problematic when there's an issue as well is the poor relationships between the midwives and the consultants. And that's a two-way street. The midwives are very jealous of their independent practice and often may be reluctant to involve a consultant obstetrician and maybe leave it too late when there may need to be a surgical intervention. And the consultants have a responsibility, in my view, to make sure those relationships are good and not to be in a standoff position, which is what you tend to find in places where things have gone wrong. So these are duties of clinicians to ethical and professional responsibilities to make sure their practice is in favour of the patient and not their own personal attitudes and grudges.
Mm. So speaking of being in favour of the patient, the very last question I wanted to ask you is on nursing. So the situation with Lucy and what has happened to Lucy and the I think particularly the degree of publicity and the nature of that publicity and the extent of it, I mean, it was relentless at one time, has had a significant knock-on effect on nursing. Now, I have got to know lots of nurses through doing this, and I've spoken to many others, and it's not just, I mean, I personally know nurses that were going to go into neonatal practice and they've said, it's too dangerous. I think I'll be putting myself in a vulnerable position. And then also I kind of receive reports from nurses who say, we don't feel we can get close to the parents now because of the accusations that have been made about Lucy as sending cards and such like, and they don't feel they can be the patient advocate in the same way that they were. So I just wondered if you could, reflect on that. And, I suppose a kind of follow-up question is how can this be improved?
Well, I get that, and I agree with it. I think it's been said now that becoming a neonatal nurse puts you at occupational risk of being accused of being a murderer. I mean, which is a horrific situation to be in. When you look at the other similar cases to Lucy Letby that have happened in other places, so that needs to be addressed. The reporting of the case, the unprofessional behaviour of some of the journalists needs to be addressed. I mean, there's an argument, really, that if people are claiming to be medical journalists, they need to have some kind of accreditation. And, that whole thing about picking on some of these human acts that Lucy did, of writing to people and following up the personal contacts it's just it's absurd, and it's obscene that she should have been painted in that way. I mean, I speak as someone who's from a family which has lots of, not a lot, but quite a number of medics and nurses in it, including one midwife in our family, And so I know what the story is, and we need to get this right. And we can't allow the media, and particularly the scurrilous tabloid journalists, to destroy a young woman and to destroy the reputation of the whole profession, which needs support at the present time.
Yeah, I agree entirely. I think that's a great way to end the interview. So thank you so much for joining us today. I'm really, really grateful. And also, I need to say thank you, not just, I think, on behalf of myself, but for everyone that cares about this issue, for speaking out and offering your expertise and experience as a very valued voice in this ongoing campaign, if you want to call it that. It's something, I care very deeply about, and I think the numbers of people that care about it continue to grow. So yeah, thank you very much for that, and thanks for giving me your time. Really appreciative.
Well, thank you, and thanks for what you're doing on behalf of Lucy as well.
Yeah, that's no problem. And thanks again on that. We may speak to you again in the future. We'll see.